So good morning all. Myself, Dr. Soumya from Senior Resident from the Department of Oncology, and today we are going to see aminoglycosides. Okay, so at the end of the session, you should be able to answer all these specific learning objectives. Okay, so these are all the objectives at the end of the session you should be able to answer. So regarding the classification of aminoglycosides, then regarding the mechanism of action, then what about the antibacterial spectrum? So whenever you are reading an antibiotic means, so what are all the things you have to study is first starting from classification, then mechanism, then especially the antimicrobial spectrum, it is very important. Okay, so it is effective against what kind of bacteria? So either it is gram negative or gram positive or cocci or bacilli. So those things are very important in antibiotics. Okay, so then comes the therapeutic uses, then doses of drugs and adverse effects, and finally, so in this chapter, especially in aminoglycosides, the dose and alteration in renal impairment patients is very essential. Okay, so this is because aminoglycosides, it is very toxic. It is toxic to the both the kidneys as well as the air. Okay, so it is nephrotoxic as well as the uterotoxic. So because of its severe nephrotoxicity, so we are going to reduce the dosage in the renal impairment patients. Okay, so those things also you have to learn, and what are all the formula to calculate the exact dose for the renal impairment patients. So those things we have to calculate. Fine, we'll move on to the session. So coming to history, just we will see a brief history. Okay, so these aminoglycosides, they are produced from the soil actinomycetes. Okay, so the first drug which has been identified is streptomycin. Okay, so in 1944 it has been discovered. So later on, many generations, newer generations of aminoglycosides has been identified. So especially why these newer drugs has been identified is mainly due to the increase in bacterial resistance. Okay, so due to the multi-drug resistance, we have discovered the subsequent drugs in the next upcoming years. Okay, and the newer drug is now we have a drug called plazomicin. Okay, so this is a current newer drug. So why the name aminoglycosides have come? How they kept the aminoglycosides? Okay, so this is especially based on the chemical structure. So here you can see there are in aminoglycosides we have two amino sugar moiety as well as a non-amino sugar moiety. So both these non-amino sugar as well as a sugar moiety, it has been clubbed together by a bond or bridge called as a glycosidic bond. Okay, so because of this, we have a name called, so there are two amino sugars. That is, from this we have taken amino and a bond. That is a 2-deoxystreptamide. This is called as the glycosidic bond. So from here they have taken glycosides. So we have aminoglycosides. So this is how they have derived the name. Okay. So we will see the classification part. So whenever you are studying a chapter, essentially the any kind of chapter it may be. So either it is an antimicrobials or a cardiovascular system, anything, the classification is very important. Okay. So here they have classified based on the bacteria or where it has been derived. Either it is a plant derivative, bacterial derivative from where the drug has been derived, as well as based on the roots. Okay, so either it is a topical application or parental application. So based on that, they have classified. So we will see the first classification. So that is a streptomyces. Streptomyces here it is a fungus. So, okay, so from streptomyces, these are all the drugs which has been derived. So you can see at the end of the drug there is mycin, mycin. So all the drugs which ends with mycin, mycin comes from the streptomyces, that is the fungal derivative. Okay, streptomycin, neomycin, kanamycin and topramycin. Okay, this pectinomycin, it is a semi-synthetic derivative. Okay. and another one micromonospora. So this micromonospora is a bacteria. Okay, so from this we have amikazin, gentamicin, sisomycin, nettlemycin, arbicazin, plasmomycin. Okay, and tramicin. So this amikazin, all these drugs ends with the mycin, MICIN. Okay, then we move on to the second classification. Here we have the both systemic and the topical classification, and that to the, so in systemic we have streptomycin, gentamicin, kanamycin, amikacin, sisomycin, nettlemycin, arbicacin, plazo and spectinomycin. So all these drugs comes under the systemic route, and either we can give it as an oral drug or as in parenteral therapy, IV or IM route, whereas in topical we only have neomycin and framycin. So with this, we are completing the classification part. Okay, so we'll come to the mechanism. So mechanism is very essential. So we have seen, so in the previous class, we have seen the beta-lactam antibiotics. So this beta-lactam antibiotics is especially, it inhibits the cell wall synthesis. Okay, so that differentiation you should be able to answer. So all the beta-lactam antibiotics, either it is in penicillin or cephalosporins or monobactams, carbapenems, all these it inhibits a cell wall synthesis. Okay, so whereas here this aminoglycosides it inhibits the it inhibits the protein synthesis. Okay, so that is a, it binds to the 30S ribosome and it inhibits the protein synthesis. Okay, so here you can see first what happens is all these aminoglycosides, it penetrates the bacterial cell wall. Okay, so penetrates the bacterial cell wall through the aqueous pores. Okay, and what happens? It reaches the periplasmic space. So this happens via the passive diffusion. Okay, so after that, for further penetration, so it acts via the active transport. Here, so further transport across the cytoplasmic membrane, it happens via the active transport with the help of energy and oxygen. Okay, so energy means ATP and oxygen. So with this we can know these aminoglycosides, one of the mechanism is via the active transport and that too via the oxygen. So it is not beneficiary in the anaerobic conditions. That means anaerobic bacteria. It is not effective against the anaerobic bacteria because those bacteria does not survive in presence of the oxygen. Okay, so this is one of the key points from the mechanism you can be able to write. Okay, so after that what happens? It goes and binds to the 30S ribosome and facilitates its action. Okay, so it blocks the initiation complex. So those things we will see. So here in this picture you can see this is an 30S ribosome and this is an 50S ribosome. Okay, and this is an mRNA with the codons. Okay, so these are all the sites which is present in the 30S ribosome. This is an exact site, this is a peptide, and this is an amino acid site. Okay, so normally before the aminoglycosides goes and binds, what happens in the bacteria means there is addition of the amino acids in this amino acid site, and after this the mRNA will send messages. Okay, so and for the protein synthesis. So these are all the things which is happening in the bacteria. So here, when these aminoglycosides goes and binds to this 30S ribosome, it blocks the initiation of the protein synthesis. So because of this, there is a misreading of the mRNA and there is addition of incorrect amino acids. Okay, so because of this incorrect amino acids, there will be synthesis of abnormal proteins. Okay, so this abnormal proteins, it is of no use for the bacteria. Okay, so automatically there will be, there will not be any growth of bacteria and essentially the bacteria will die. So by with this it produces a bactericidal enzyme. So that is a killing of bacteria. Okay, so again we will repeat this mechanism. So what happens here? So this aminoglycosides goes and binds to this 30S ribosome and blocks the initiation complex. Okay. So because of this, there is misreading of the mRNA and incorrect amino acids comes and bind to the site and there is abnormal protein synthesis. So this abnormal protein synthesis, it leads to ill. So it is of no use to the bacteria and there is defective growth and essentially the bacteria will die. This is what happens in the bacteria. Okay. So coming to spectrum of activity. Okay. So whenever you are reading an antimicrobial chapter, so the spectrum of activity is very essential. Okay. So here aminoglycosides, the primary effective, it is effective against primarily gram-negative aerobes, okay, aerobic bacteria. So what are the gram-negative bacteria we know? We know E. coli, then Klebsiella pneumoniae, then Proteus. So then Salmonella, Shigella, all these things. Okay. So with this, so we'll see the which drug is effective. So here amikacin is better than topramycin and which is better than gentamicin. Okay. So and then it is effective against few gram positive cocci also. So that is Staphylococcus aureus, then Streptococcus and Enterococcus. Okay. So but the primary thing is gram negative bacteria and few gram positive cocci and finally some mycobacteria. So mycobacteria means tuberculosis. Okay, tuberculosis is caused by Mycobacterium tuberculosis bacteria. Okay, so here streptomycin, it is used as an first line drug that too, but nowadays it has been kept as a reserve drug. Okay, so whereas other drugs like amikacin, kanamycin, it has been used as a second line drugs, but now these second line injectables has been restricted and in newer guidelines, that is a NTEP, okay, National Tuberculosis Elimination Program. So here this use has been declined, okay. So now we will see the concentration dependent killing. What is that? Okay. See, this aminoglycosides especially has a special effect called as a concentration dependent killing. So that means, so the amount of bacteria, so sorry, the amount of aminoglycosides, the how much amount is present in the plasma. So if the aminoglycosides level is high means, so it kills the much amount of more amount of bacteria will be killed and that too at a higher rate. Okay, so based on the concentration of the aminoglycosides, the bacterial sidal effect will be present. Okay, if it is higher, the concentration is higher means the bacterial killing will also be higher. The sidal effect is higher. Okay, so whereas regarding the post antibiotic effect, so post antibiotic effect. So what do you understand by the term? So even after the drug reaches the minimal inhibitory concentration. So after that also the antibiotic, the sidal effect will be still be present in the plasma. So that is called as a post-antibiotic effect. So this is one of the special effect of aminoglycosides. Okay. So what are all the other drugs which have the post-antibiotic effect? So apart from aminoglycosides, we have tetracyclines as well as fluoroquinolones which exert the post-antibiotic effect. Okay. So because of this beneficiary effect, so here you can see the T half was given as written as 2 to 3 hours. So the half-life is 2 to 3 hours means what happens? The half-life here is 2 to 3 hours means so we can give the drug 6 times. So that means 4 times a day we have to prescribe the drug. So because of this post-antibiotic effect, we are going to give the drug as a thrice daily or twice daily dose. Okay, so this is one of the beneficiary effect. So we will see the resistance. So whenever we are giving an antibiotic, okay, so as all the antibiotics, it has been drawn to resistance. So here you can see the bacterial enzymes. So this plasmid mediated bacterial enzymes, it causes inactivation of the aminoglycosides. Okay, so as well as there will be any mutation or deletion. Okay, so the deletion of the purine channels. So via these purine channels only the aminoglycosides have to enter the bacterial cell. So what happens if there is any mutation or deletion of the purine channels means, so the aminoglycosides entry itself is restricted here. Okay, so this is one of the mechanism for resistance. Or there will be non-functional O2 dependent transport system. So the active transport here is non-functional. Okay. So these are all the basic mechanisms for resistance. So coming to pharmacokinetics. So pharmacokinetics is very important. Okay. So whenever you write a drug, you have to write this pharmacokinetics. That is very essential. So this aminoglycosides, it has very poor oral bioavailability. So because of that, we are going to give this drug in an either an parenteral route, that is intravenous or intramuscular route, or else we can move on to topical formulation also. Okay, so either if it is given as an ointment or the ear or eye drops, we can give the drug. Okay, so it is especially cleared by the glomerular filtration. That is a parenteral route. 90% of the drug it is cleared, and it will the higher concentration of the aminoglycosides present in the it will be present in the urine. So because of that, this drug can be used in the urinary tract infection. So that is one of the beneficiary effect. And also, as these drugs are very active at the alkaline pH, so when for urinary tract infection patients, if we use an alkaline syrup. So that is alkaline citrate syrup. If we use that, so this action, that is effectiveness, will be little bit much higher. Okay, and also this regarding the excretion, it is directly proportional to the creatinine clearance. Okay, so because of that, we have to reduce the dose in the renal impairment patients. Okay. So now we will see the uses. Okay. So these are all the common uses which I have been noted. So we will see the separate drugs later in the subsequent slides. Okay. So these are all the common therapeutic uses. So what are all the uses? Serious life-threatening, gram-negative infections, then complicated skin, bone or soft tissue infections, and in complicated urinary tract infections we can use, and in sepsis, peritonitis, and also along with metronidazole, that is an anti-amoebic drug, we can use gentamicin in the severe pelvic inflammatory disease and endocarditis. Then streptomycin can be used, and mycobacterial infection. So what is the drug which has been used in mycobacterium tuberculosis? Streptomycin. Okay, streptomycin as well as second line injectables. But now the second line injectables has not been used and it has been replaced by oral, shorter and longer regimens. Okay. So then neonatal sepsis and ocular infections in otitis externa. Okay. So regarding the uses, so this picture with this picture you can categorize these uses based on the systems. Okay. So it will be useful for you to remember. Okay. So for this purpose, I have projected this. We'll skip the slide. So we'll see the adverse effects. Okay. So whenever you read aminoglycosides, so first thing which come to your mind should be the adverse effects. Okay. Because it is more prone for ototoxicity as well as nephrotoxicity. Okay. So ototoxicity, especially the eighth cranial nerve. So what is the eighth cranial nerve here? That is vestibulocochlear nerve. Okay, so this vestibulocochlear nerve is affected here. Okay, so what happens is aminoglycosides, it goes and it gets accumulated in the endolimb or the perilimb of the vestibular and cochlea and causes toxicity. So if the patient is having vestibular toxicity means they may be suffering, they may be experiencing this vertigo and ataxia, whereas cochlear toxicity means they will be experiencing this tinnitus and hearing loss. Okay, so we will see what are all the drugs which is ototoxic as well as the cochleotoxic. Okay. So the most ototoxic, this is a common thing. So topramycin is both cochlear as well as a vestibulotoxic. Here you can remember like this, OT. So topra, T for topramycin. Okay. So whereas for cochlear toxicity, you can remember like this. So drugs are amikacin and neomycin. So here you can remember as CAN, CAN, or else you can remember Amit for amikacin. Then he bought a new cock, new for neomycin and cock for cochlear toxicity. Okay, so whereas for vestibular toxic, streptomycin and gentamicin are the drugs which is more vestibular toxic. So with this you can remember gens. Gens means gentamicin, steps means streptomycin. Okay, is in the west side. West means directions we are telling. West, east like that. But here for your sake, I have written the spelling as instead of W, I have written west. Okay, so it will be easier for you to remember. West means vestibulotoxic. So like this, you can keep mnemonics and study the drugs. You won't forget these things. Okay. So coming to nephrotoxicity. So we have seen what are all the drugs which causes nephrotoxicity, and regarding the nephrotoxic drugs, we have amikacin, gentamicin, topramycin, and neomycin. Okay, so these are all the drugs which causes nephrotoxicity. So this you can remember like for gens, Amar bought a new top. So that means gens means gentamicin, Amit means amikacin. He bought a new top means neomycin and topra mice. Okay, so these are all the drugs which is more nephrotoxic. And coming to another one major side effect is neuromuscular blockade. So streptomycin is the one which causes these adverse effect. Okay, so this is especially important in myasthenia gravis patient. So with this, we have seen what are all the things up to till now we have seen. We have seen the classification part, that is very good. Okay, then we have seen antimicrobial spectrum, and now you know what are all the common therapeutic uses and adverse effects, and finally we are going to see what are all the precautions and interactions. Okay, so regarding the pregnancy, so this aminoglycosides, it is avoided in pregnancy. Why? Because of the teratogenic effect. Because aminoglycosides are ototoxic as well as the nephrotoxic drugs, it causes fetal teratogenicity. So we should not definitely use these drugs in the pregnancy. Okay, and also we should avoid the aminoglycosides used with other ototoxic and nephrotoxic drugs to prevent the extreme toxicity level. Okay, so and again last point is regarding the drug-drug interactions. So that is avoid mixing with penicillin in the same syringe or the IV fluid. Okay, so this is because the penicillin is a beta-lactam antibiotic, so it inactivates or decreases the efficacy of the gentamicin when we give the both the drugs in the same syringe or the same IV fluid. Okay, so it inactivates. So efficacy of gentamicin will be decreased. Okay, so we should not use this club these two drug together in a same syringe. Okay. So now we will see the individual drugs. Okay. So first drug is streptomycin. This is the first drug which has been identified. So this drug it is more prone for resistance. Okay. So bacterial resistance. Okay. Rapid resistance will be there. Okay. So it causes lowest nephrotoxicity, whereas it is more prone for resistance, and also it is used as a reserve drug for tuberculosis. Okay, you know that. Okay, so previously we have been using the drug, but now it has been kept as a reserve drug. Okay, so apart from tuberculosis, it has been used in subacute bacterial endocarditis. So with along with penicillin, we are using streptomycin in subacute bacterial endocarditis. Okay, so for 2 weeks we are using this drug. Okay, and in plaque brucellosis, tularemia also we are using this drug. So we are using it in a dose of 1 gram per day. I am with oral tetracycline. Okay, now we see gentamicin. Okay, so regarding gentamicin, So this drug, it has been obtained from the micromonospora. Okay, micromonospora, and it is more potent also. Okay, so for the T half here is 2 to 4 hours. And one of the important effect is it acts synergistically with beta lactam antibiotics. So that means, so this beta lactam antibiotics, what is the mechanism here? So this beta lactam antibiotics, it what happens? It inhibits the cell wall synthesis. So if the cell wall synthesis is inhibited, means what happens? The aminoglycosides, it can easily enter the bacteria and exert its bactericidal effect. So this both these drugs, beta-lactam as well as gentamicin, are given together, means the effectiveness of the drug is quite higher. Okay, apart from giving it separately. Okay, and also it has broader spectrum of action. So it is active against Pseudomonas, Proteus, E. coli, and Klebsiella. One of the major drawbacks is it is more nephrotoxic. And what regarding the uses, it is used in the critically ill patients who are in the ventilators as well as a host of patients in ICUs. We can use gentamicin, and also subacute bacterial endocarditis and meningitis as well as the burns, lung abscess, pelvic infections we can use. So I have told you before. So in pelvic infections, along with metronidazole, we can use gentamicin. Okay. So and it is a cheaper drug also. Okay, fine. So we'll see kanamycin. So the kanamycin is considered as a second line injectable anti-tuberculous drugs. So according to RNTCP guidelines, it has been used as a second line injectable anti-tuberculous drug. But now it has been based on newer guidelines, that is NTEP. We are not using it. It has been replaced by oral and longer shorter regimens. Okay, it's for multi-drug resistant cases. And it is also highly ototoxic and nephrotoxic. And next drug is amikacin. So amikacin, it is a semi-synthetic derivative of kanamycin. Okay. So mainly, what are all the drugs which has been, that is a gentamicin as well as topramycin. If there is having a bacterial resistance, if the patient is having a bacterial resistance, based on the culture review, we will find the resistance, and the appropriate drug will be given. So here, so if the patient is already gentamicin and topramycin in resistance, means in that case we can use amikacin. So it is of higher beneficial use. Okay. So it has been kept as a reserve drug only in resistant cases. Okay. And also it has a broad spectrum of activity. Okay. So apart from this, I have told you kanamycin and amikacin, it has been used as a second line injectables in multi-drug resistant tuberculosis. But now the use has been decreased. Next drug is cizomycin. So this drug, it is more potent on the Pseudomonas and beta hemolytic streptococcus. Okay. And second point, it is interchangeable with gentamicin. So that means, so if the gentamicin is given for a specific condition as well as the specific dose of gentamicin is used with the same dose and the same indication, it applies for cizomycin also. Okay. And it can be combined with a beta lactam antibiotics for synergistic effect. Okay, so there is an additional. Okay, so another drug is netilmycin. So this netilmycin is, it is also having a broader spectrum than compared to gentamicin, and it is used in the critically ill patients. Okay, so this has been use has been restricted to critically ill patients. So next drug is neomycin. So this neomycin, so it is not used systemically because of its toxicity. So that means it is both nephrotoxic as well as the ototoxic. So because of this toxicity, we are not going to use it in the parenteral use or either oral therapy. So we are formulated a topical application. Okay, so topical applications means, so combined with polymyxin basic resin, we can use this drug in the burns, then scalds and minor wounds also. Any cut injuries also we can use. Okay, so this is a ointment. So this is a combination of therapy we are giving. Okay, so apart from this, for the oral use, it has been restricted to only these two indications. Okay, so one is as an oral antiseptic before the preparation of bowel surgery. Okay, so 1 gram TDS will be given. Okay, and another thing is hepatic coma. So in these patients, there will be protection of ammonia. So it leads to the encephalopathy. So to prevent this, neomycin can be used. Okay. So these are all the two indications of the oral therapy of neomycin. The use has been restricted only to these indications. Okay. So regarding pramycetin, it is used as a topical formulation mainly for any skin infection, that is also as a drops formulation in otitis externa. Okay, and also in bacterial conjunctivitis we can use. Okay. Next drug is arabic acid. So this is having a potent broad spectrum activity. Okay, so this is one of the newer drug and it is effective against MRSA. So MRSA means methicillin resistant staphylococcus aureus and as well as the gram negative pathogens. It is very effective. Okay. And plasmomycin, so this is also the newer drug. So it is effective against the extended spectrum beta lactamase producing Enterobacteriaceae as well as the carbapenem resistant Enterobacteriaceae. And also it can be used in the bloodstream infections. Okay, so the dose is 15 milligram per kilogram per 24 hours. So that means once daily for 4 to 7 days we can use this drug. So last drug is pectinomycin. It is effective against the Neisseria gonorrhoeae and it is given by intramuscular injection only. Okay. So this is one of the newer formulation because the inhaled aminoglycosides. So already this inhaled tocramycin, it is available in European countries as well as United States. For cystic fibrosis, they have been using this inhaled tocramycin, and still this inhaled amikacin and albicacin as in development. Okay, so both for cystic fibrosis and respiratory tract infection. So this they have discovered. So it is still inventing, sorry. So especially to prevent the systemic toxicity. Okay. Okay. So to prevent the systemic toxicity, so the route has been inhalational route has been preferred, and they are still developing. So with this, you can like this, you can put a chart and you can remember easily regarding the aminoglycosides. Whatever topic you are reading, either it is cephalosporins or fluoroquinolones or macrolides, you can write like this. Okay, take a paper and write like this, put a heading like this, and the key points alone you write. Okay, so the key points means here you can see the mechanism also. It inhibits the protein synthesis by binding to 30S ribosomes. So that is a key point, right? Okay, then bactericidal effect. Okay, like this, fewer drugs has been written and side effects and spectrum of activity as well as the PK has been written. So these are all the essential things for an antibiotic. So you can take a paper and or put a chart like this and remember at the for examination purpose you can use it like this. Okay. Okay, fine. So this is just a small distraction for you. Okay, so this is a puzzle we have given here. So this is the kidney. So kidney means which drug causes nephrotoxicity. So okay, so with these three pictures, so these are all the puzzles I have given. So you have to remember you have to tell a name which is more nephrotoxic. Okay, can you able to answer it? So he's a gents. He's considered as a male or gents. Okay, gents we can take an ami. Okay, so gent ami sim. So that means the drug name is gentamicin. Okay, so you can see one of the multiple choice questions. So it's an examination purpose. You have a 20 marks for multiple choice questions and then 80 marks for the short answers as well as the essay. Okay, so total 100 marks. Okay, so whenever you are reading a chapter, you itself you derive an MCQ and read. Okay, so here one of the MCQ I have put, which of the following group of antibiotic is given together with aminoglycosides for synergistic action? Okay, so that means we have macrolides and sulfonamides and beta lactam. Okay, so in the initial period itself, I have told you. So gentamicin, it can be given along with the beta lactam antibiotics for better synergistic effect. Okay, so the answer is beta lactam antibiotics. So these are all few statements. So aminoglycosides or bacteriostatic drug. So you have to tell whether it is a true or false. Okay. So these are all not bacteriostatic. This is a bactericidal drug. So it is a false statement. Okay. Then second thing is aminoglycosides. It acts by inhibiting the cell wall synthesis. Okay. So either so what are all which is the drug which acts by inhibiting the cell wall synthesis? That is beta lactam antibiotics. Okay. So antibiotics, it inhibits the protein synthesis. So this statement is also a false statement. Okay. So the third point, so beta lactam antibiotics as post antibiotic. It is either true or false. It is also false because aminoglycosides, fluoroquinolones, and tetracyclines have a post antibiotic. Okay. So I have told you before itself, as aminoglycosides are more nephrotoxic. So for a patient with who is having a renal impairment or renal insufficiency, we have to reduce the dose for that patient. Okay, so here you can see the dose of, so this is one of the formula. So based on the creatinine value alone, we are going to calculate it. So this is the normal, simple, basic formula. So we are not going to use it in exam or in pharmacoeconomic problems and all. So we are going to use it in a it's a different formula, but these are a few basics you should be able to know. Okay, so before that, you should be able to answer what is creatinine. Okay, so what is creatinine? Creatinine is nothing but it is a byproduct of the muscle protein metabolism. So this what happens, this byproduct, it has to be excreted by kidney. So by glomerular filtration, it has to be excreted. If the patient is already having renal impairment, means what happens, it gets collective. Okay, it gets accumulated in the plasma, blood plasma. So this has to be, it is the creatinine level will be raised in the patient. Okay, so with this, you have to know what is the normal serum creatinine level. Okay, the serum creatinine level is from zero point 0.7 to 1.3 milligram per deciliter for male patients. Okay, so there will be mild variation in the females. Okay, so 0.7 to 1.3. So here this is a 70 kilogram male normal patient who is having a creatinine level of 1 milligram per deciliter and who receives a 350 milligram per day of gentamicin. So see, this is a male patient. So the normal value I have told is 0.7 to 1.3. So that means it is within the normal limit. Okay. So we are not going to reduce the dose. So exact dose can be used. So here for gentamicin, the dose is 5 milligram per kilogram per day. So 5 milligram means, so if you can calculate the weight now for this patient. 5 milligram for 70 kilogram means it will be 350 milligram per day. We are going to give, either we will give it as a single dose or the divided dose we will be giving. Okay, so here, so with this example you are going to solve a problem case scenario. Okay, so here you can see again a male case only, 55-year-old male with urinary tract infections. We are going to prescribe gentamicin, but his creatinine level is 3.5 milligram per deciliter. So how will you calculate the appropriate dose for this patient? Okay, so with this, you have to derive. So here the patient is, so the weight you can keep it as 70 kilogram. Okay, 70 kilogram, same 70. Okay, but the creatinine level is less or low, it is higher. So the normal dose is 0.7 to 1.1, sorry, 1.3, but here it is 3.5. So that means the creatinine level is higher for this patient. So the normal dose, what is the normal dose? 350 milligram. Okay, so 350 milligram for 70 kg patient. Okay, so here the creatinine level is 3.5. So based on this formula, you can calculate normal therapeutic dose by serum creatinine value. Okay, here the normal therapeutic dose is 350. We know that, and serum creatinine level is 3.5 for that patient. So that means 350 milligram divided by 3.5, 100 milligram per day. So the dose has been reduced. That is 100 milligram should be given to the patient. Okay. Okay. So I have told that is those are all few basics. Okay. So this is a very essential and exact criteria to be formula to be followed to calculate the creatinine clearance. Okay, so what is creatinine clearance? We know creatinine is a byproduct. What about creatinine clearance? So it is an how much amount of creatinine is excreted per minute. Okay, that is called as a creatinine clearance. So we are going to calculate this creatinine clearance rate based on the formula called Cockcroft-Gault formula. So it can be asked in Viva. Okay, so if at all they are asking questions on aminoglycosides, means definitely they will ask this formula, that is a Cockcroft-Gault formula. Okay, so this is used based on the weight of the patient as well as the gender. Okay, so if a patient is a female, means we are going to multiply it by a 0.85. Okay, to correct for the lower creatinine clearance. Okay, so here age is a main predictor. So this is the formula. So 140 minus age into mass kilogram into 0.85 if it is a female, divided by 72 into serum creatinine level. Okay, so based on this you will estimate the creatinine clearance. So, so we will leave all those things. Okay. So we will see a case scenario. So a 75-year-old male patient, unconscious patient of cerebral stroke. So he has been maintained on ventilator in the intensive care unit. On the fourth day of admission, he developed fever and his leukocyte count, it has been raised to 14,000 per milliliter, and is also having signs of chest infection. Okay, so now we are going to take an bronchial aspirate sample, and it has been sent for the bacteriological investigations, and we are going to start the treatment with cefotaxime and gentamicin. Okay, so cefotaxime is a third generation cephalosporin and gentamicin is an aminoglycoside. Okay, so his body weight is now 60 kilogram and creatinine clearance is also based given 50 ml per minute. Okay, now we are going to calculate what should be the appropriate dose and dosing regimen for gentamicin and cefotaxime for this patient. Okay, so here in this patient, the recommended doses, so normal dose we have to do for gentamicin 3 to 5 milligram per kilogram per day is a normal dose. So we can take the 4 milligram as an average. Okay, so the patient, he is having a creatinine clearance of 50 ml per minute mean. So the dose has been reduced, should be reduced to 50%. So that means 50% means 4 in 4, 50% means 2 milligram. So we have taken 2 milligram per kilogram per. So now we know the patient age. Okay, so the patient, weight is 60 kilogram. So if we multiply with this dose for 60 kilogram patient, 2 milligram means it will be 120 milligram per day. Okay, so we are going to give 120 milligram per day for this patient. Okay, but due to the renal impairment, we are not going to give it as a single dose. We are going to give it as an 8-hourly regimen. Okay, so that means we are going to give thrice daily. Okay, fine. So here we may inject this gentamicin 40 milligram every 8 hours. Okay, so this is how we are going to split this 120 milligram. Fine. So now we know the gentamicin dose. We have to calculate the cefotaxime dose. Okay, so here the cefotaxime normal dose range is 1 to 2 grams for an adult, and we have to give it as every 6 to 12 hours. Okay, so that means 2 to 8 grams per day. But this patient is already having the renal insufficiency. That means the half-life of cefotaxime may be prolonged. Okay, so what we have to do is we have to give a dose which is near the lower end of the range. Okay, so that means near the lower end means the lower end is here is 2. So near the lower end means we can calculate as a 1 gram every 8 hourly. So that means the patient is going to get 3 grams per day. Okay, so this is the dose of cefotaxime. So now we have calculated both the doses for gentamicin as well as the cefotaxime. Okay, so this is how we are going to calculate the doses for the renal impairment patients in the future. Okay, so you have to know all these formulas as well as the concepts for to calculate the doses of aminoglycosides in the renal impairment patients. Okay. So, okay, thank you all. So, with this we are completing the session. Okay.